This presentation is entitled Temporomandibular Disorders Review, specifically for otorhinolaryngologists, ENTs. What's the purpose? Those are to improve TMD assessment for better diagnosis and treatment success of our patients, our mutual patients. It's given by the Atlanta Tmd Institute, which was founded in 2018. We're located at 1640 Piedmont Ave, Atlanta, Georgia 30324. And you're very welcome to call, visit, or get information on our website. So what is the Atlanta Tmd Institute? It has three primary purposes, and we're satisfying one by providing you this education. First and foremost, to educate dental and medical professionals in TMD, and for the last 2 years, we've been giving exclusively dentists accredited courses in TMD in Georgia. We are going to begin moving outward into Alabama, South Carolina, and Tennessee. The Institute has accepted patients from Alabama as far as Huntsville, North Carolina as far as Raleigh, and Gainesville, Florida. So we've got people from all over the Southeast United States coming. Second purpose of the Atlanta Tmd Institute is to develop knowledge of TMD. Unfortunately, it is a stepsister, and there's very little information, a lot of confusion, and it's not taught in most dental universities. Reason being, it's not a specialty. So there's no questions on the boards. So why teach a dental student something that is not going to be on their boards? And so this is a problem. And finally, the Institute is to successfully treat patients suffering with TMD. So we're educating dentists, but we're a fallback opportunity for them so that they can feel safe treating people and know that we're here to treat any complex case at any time. Because most dentists do not do this care. They feel worried about it because there's no background information at the universities that they went to. So they have to sit and read and learn by themselves, which is something that most people don't have the time to do. Kind of like to begin this lecture with a tribute to a physician, John Hickam, who said, "A patient can have as many problems as they damn well please." So, and it's referred to as Hickam's dictum. And interestingly, his dad, his father, Horace Hickam, was actually the primary person running Hickam Air Force Base during the bombing of Pearl Harbor. But this is a tribute because you need to be thinking that case presentations can be complex, etiologies can be complex, and you need to list out everything and don't just focus on what you were trained in. Try to recognize problems that the patients have in general, globally, so that you can better treat patients. But I was introduced to this gentleman's thoughts by one of my mentors when I was a student at Emory. And oddly enough, this gentleman was the house staff physician at Grady Hospital in 1946. The ear and the temporomandibular joint are anatomical next-door neighbors. There are numerous interconnections among ear function and masticatory function, and we will review some of these connections in this video. It appears to be a human character that we become myopic in the area that we are highly trained. Certainly this is true in religion and creates all kinds of problems. And I'm hoping to open and present some things to you that may not have been previously presented. Hopefully, after viewing this presentation, you become interested in how temporomandibular disorders may be an underlying etiological cause of many otologic, laryngeal, and nasal symptoms that present to you in your daily ENT practice. This is a really wonderful picture, and it illustrates some of the things that I'm trying to express. You can see the malleus and the incus right there in the ear canal, past the ear canal. Obviously, the tympanum is removed, but the condyle is just adjacent to that structure. In this particular instance, the condyle is in its relatively correct position. You'll notice there's space above the top of the condyle between it and the mandibular fossa. There's a space behind and the space forward, and the space above and forward is for the disc. The posterior aspect, the space between the back of the condyle and the front of the ear, is supposed to be open, and there should not be compression. The joint does not function back in this space. It's not supposed to. But you will see that is not always true. The ear and the temporomandibular joint both develop from the same primordial embryological structures. They have common embryologic and phylogenetic origins. It's really quite amazing how God can repurpose structures and have them do other things that are more efficient and better. In fact, the malleus and the incus are first arch structures that are jawbone remnants of our ancient reptilian ancestors. Stapes is a second arch structure that is also a jawbone remnant of fish. So earlier, first came fish, and then reptiles went up onto the land as amphibians and then developed out. Given this fact, the evolution of the jaw preceded the ear's development. Well, that makes sense if you just look at evolution. And the evolution of feeding preceded that of hearing. And hearing was dependent on the evolution of feeding first. And this is an extremely important thing. And so there's also integrative structures because of their common origins. So we see a lot of interrelationships. And it should be taught to ENTs because there's just a number of different interconnections because of this evolutionary development. This is a ENT, not a dentist. His name is Dr. Costin. And in 1934, he described a syndrome related to the ear and the jaw. And I have previously sent out a copy of this paper to a number of ENTs. It's probably one of the things, hopefully you've read it, take a good look at it. The posterior dislocation of one or both mandibular condyles into the anterior wall of the external auditory meatus and the anterior wall of the middle ear cavity, along with many of the other common accompanying signs and symptoms associated with this, was first described by an ENT, not a dentist. So this is, again, ENT, Dr. Costin. Dr. Costin first described Costin's syndrome in 1934. Unfortunately, the field of otorhinolaryngology has not continued to pursue this interest and not integrated at all with dentistry, which is a sad thing, but you're getting interested in it, and this is a wonderful thing, and hopefully we will integrate this. And it is, I think, essential. But Dr. Costin called it a syndrome, and a syndrome is when you see consistently in every single case all of the signs and symptoms, like Down syndrome. TMD, temporomandibular disorders, the word disorders is key here, is not a consistent thing. And I like to tell when I'm teaching, it's like going to the Piccadilly cafeteria. There's lots of food, different foods you can choose from, but everyone in Piccadilly is having a meal. But each person's meal is different, but they're all in Piccadilly. So we have a whole list of signs and symptoms associated with TMD, but you don't necessarily have to have each one and every one. So it is called, more appropriately, a disorder. And unfortunately, dentists, not being anatomists, initially allowed the term TMJ to be promulgated, and it's not TMJ. That's a joint. Every person has two normal TMJs in most cases. No physician orthopedic guy would say, hey, you have knee, we need to do something about that. So it is more appropriately called TMD to refer to the cluster of symptoms, signs and symptoms that may occur. This is a really interesting diagram that is taken from the Knie-Funt-Stack Visual Index, which is a form with questionnaires. There's a questionnaire attached with this form to screen TMD patients. And it was invented by one of my mentors who is retired now in Washington, D.C. And it says, do you suffer from any of the following? And please note, we've got throat on the bottom, swallowing difficulties, laryngitis, sore throat with no infection, voice irregularities or changes, frequent coughing or constant clearing of the throat, and a feeling of a foreign object in the throat constantly. You have to remember that the larynx is primarily probably suspended by the mandible. So dysfunction in the mandible, particularly posteriorization of the mandible, are going to cause compression and even sleep apnea problems. On the top right, you see ear problems, hissing, buzzing, or ringing, decreased hearing, ear pain, earache, no infection, cloggy, itchy ears, and also, quite interestingly, vertigo and dizziness. This is critical because vertigo and dizziness do not have to be an inner ear problem. And it's extremely important. A pretty famous physician, Janet Travell, who was the founder of physiatry, did many different experiments, and one at Georgetown University, and she noted that the sternocleidomastoid muscle, which is almost always involved with TMD problems because of the stretching of the joint, will cause dysfunction in that muscle. The middle component of that muscle will in fact cause, guess what, vertigo and dizziness. And it often resolves after TMD treatment because it is a functional problem. In other words, the inner ears orient the head to the visual plane along with with vision. So if your eyes are closed, the inner ear orients right and left like a gyroscope, which you're well familiar with. But the head is the only part of the body that has this orientation device. The rest of the body does not. So the rest of the body has to twist and turn and connect to that head. And one of the primary muscles that seems to take this proprioception and orient the body is the sternocleidomastoid muscle. Very interesting. But there are more connections than just this photograph, including nasal, because you can have parasympathetic problems in the nose, like a runny nose, related to some TMD problems. So what's interesting is how much the brain visualizes the head, all the attention. It's about 50% of most of the sensory perception in the human body is in the head. So the extensive number of signs and symptoms found in temporomandibular disorder patients is really quite amazing. Again, this is probably because of the huge amount of sensory reception or representation of the head in the central nervous system. We're talking also about feeding, which, survival, you must feed. So a lot of the attention of the central nervous system is acquiring food and processing food. The trigeminal nerve, which provides sensation intranasally, which is interesting. It certainly does more than that, but I'm just to understand it. I've always been interested in sneezing and lung function. It's like, whoa, what's that connection? But the temporomandibular nerve provides sensation intranasally. It's also the primary sensory and motor dental nerve. So we're talking about dental stuff. This fifth cranial nerve is involved in a myriad of functions and dysfunctions, including migraine, cluster headache, TMD, coordinated lung expansion, and much more. Your face is you. So it is very, very important. Another really interesting concept is in migraine. So it's the same trigeminal nerve, and neurologists often will put Botox along the temporalis muscle, and that will decrease migraine. So why does a muscle stop migraine, which is supposedly vascular? It's an interesting topic. I love talking about it, but I believe there have been research that the dural nerves go through the cranium into the attachment of the temporalis, and by putting Botox, you're stimulating and non-stimulating, but calming down these fibers and decreasing the irritation of the trigeminal nerves that also serve the vascular functions. Muscles serve joints. So when you have a joint problem, you're almost always going to have a muscle problem. In fact, 90% of TMD patients have musculoskeletal problems and present with muscle pain. So, and that's usually the most acute type of pain that they experience. There's also something called the arthrokinetic reflex, meaning that the joints have a direct reflex connection with the muscles that serve that joint. So, and this has been demonstrated by Clark, a physician, in decorticated cats, which means that if you decorticate a cat and you stimulate a joint, and remember there's no higher CNS connection, the muscles will respond. So there's a direct reflex connection between the joint and the muscle. The masseter muscle just seems to be involved all the time in almost all TMD patients, particularly when it's unilateral. On the ipsilateral side, that masseter is going to be tight, dysfunctioning, and painful. So as part of a screening exam, you always palpate the masseter muscle. So you intraorally do it. You place your, if you're palpating the patient's right side, you place your finger in the mouth intraorally, thumb on the outside adjacent. You go upward and compress and go upward against the zygoma and the zygomatic extension of the temporal bone, and compress. And if it's painful, you know that there's a joint problem because it's connected. The masseter is just involved all the time. And if you look at the masseter, this is extremely important comment that I'm making for you as ENT. You have one that angles forward, and there's a huge epineuritis. And then there's a portion of the masseter under that's more vertical. If you look at the left skull, there's a vertical portion, and guess what? When that muscle goes into spasm, it causes tinnitus. Oh, Lord Almighty. Did anybody ever tell you that? So you're thinking tinnitus has to be an ear problem. Absolutely. No, not true. This has been, again, proven with Janet Travalla, a physician who did trigger point injections, irritated the hell out of certain muscles, and asked Georgetown students, where are you hurting? What's happening with you? And when she injected the deep portion of the masseter muscle, one of the symptoms that she could elicit was tinnitus on the ipsilateral side. But I'm presenting this particular muscle because it's going to be part of a screening exam. It takes no time for you, very little time. And I'm giving you the screening exam first because you might get, just busy and not finish the video. So I think the screening is probably really way more important than some of the other interesting stuff, because if you screen them, you'll know that there is a connection and a problem. This is a illustration of the temporalis muscle. Temporalis muscle is a really interesting muscle. It's a muscle of mastication and considered an elevator and a retruder of the mandible. You can see its fibers. The back fibers are almost horizontal and down, and the anterior fibers are up and forward. It is an extremely interesting muscle. The anterior temporalis particularly is very often involved with TMD. So it will dysfunction, and you can palpate the anterior temporalis, and if there's pain there, pretty much an indicator that this person does have a TMD problem. Now the anterior temporalis is behind the eye, perhaps slightly superior than this illustration. They've cut the zygomatic arch off. You're not going to palpate there because that's the zygomatic arch. It's protected. You can palpate above. And I like using one hand, forefinger and thumb, both sides of the skull. Ask the patient to bite down hard. Feel it where it is. Move your fingers to the bulge and then press. And that will create pain. And if in a TMD patient, that will create pain. You can do it with two hands too. Normal joints do not hurt when they're moving, and they don't hurt when they're compressed. You can apply some pressure on the patient's elbow or knee and have them move, and they see that a normal joint does not hurt when compressed or moved. You need to watch the patient. So what you're going to do here is palpate both of the temporomandibular joints simultaneously, and you're going to basically palpate pre-auricularly your area while the patient opens and closes. So you take your forefinger on your right hand and place it on their left joint, and then your left finger on their right joint, and have them bite all the way down, and open and close, and feel for the lateral pull of the condyle. You can go back, you can buy a skull, plastic skull, for like $50. It's always good to have it around, especially when you're teaching patients. And you feel for that lateral pull moving. Then you know where the lateral pull is, then you'll know that what? The back of the joint is behind that lateral pull. So you have the patient open after you've identified that where those are. Place your fingers behind the lateral pull, compress, patient hurts. That's bad news. That means that there is inflammation in the tissue behind the condyle and in front of the external auditory meatus and the middle ear wall. So that is not normal. And it means that the joint is being irritated for one reason or the other. We don't want to get into diagnosis, but we do know that the person, it's not a normal thing. And you'll also place your fingers in their external auditory meatus. Go forward with your pinkies. Have them bite. First, you do this when they're open. So they open, put your pinkies in, pull forward, have them bite all the way down into their complete maximum bite. A lot of times they won't, and you'll see this. You got to look. And then you'll actually feel that condyle compressing into the lateral portion of the ear. Yeah, and it is. It's hitting into the ear. Not good. And that right off knows, you know that you're into some trouble. As we explained, the ear and the temporomandibular joint are on the same temporal bone, and they, however, are separate entities. So when a person bites down, if the condyle rams the external auditory meatus in the middle ear, you can usually palpate that. You take your pinkies, make sure your fingers are, you're trimmed, the nails are trimmed. Apply forward pressure and inward. Sometimes have to rotate forward, touching the whole ear canal while the patient's open. Then ask the patient to close. And if you feel significant pressure from that posterior pressure of the condyle, that's a problem. That's what Costin was talking about. Additionally, very often, interestingly, the patient will open, you'll do this palpation, they'll close, and you hear that click, and the click is pushing the reduced articular disc off when they hit and ram the posterior aspect of the condyle into the ear. There's just no room, so the disc has to spit forward, and it makes a clicking sound.
First thing we're going to do is just check her temporalis. Hold both sides. Bite down hard, please. I'm feeling for the bum. I'm repositioning my fingers. Bite down hard again. Great. Then I compress it. Bite down hard. Good. And I ask her if she has any pain. No, this is a healthy patient. She doesn't look healthy, but she is. Next thing is going to be the joints. I want you put your fingers in front of the ears. Open, and I'm feeling it open and close, and I'm getting my fingers closed and open, and then I press and close and open. So I'm actually pressing on these joints, close and open on both sides to see if there's any pain on pressure or opening and closing. So it's very quick. I mean, you're like bite, okay, open, close, open. So I can do that very quickly. The next thing is the masseter, open, and I come in, I drape her cheek out, I go up, I'm up now, bite down, and bite hard. And now I press on the top of the muscle with my thumb on the opposite side, up, bite hard, I feel the muscle, open just a tad, and I press. And there should be no pain on the masseter muscle, in the joint, or up in the temporalis. Thank you. Thank you.
One of the non-masticatory muscles, and I hate to say that, it's not a muscle of mastication, but I believe it is a muscle of mastication. So, what am I saying? Well, in order to use your canines, you need to be able to rip the tissue, and the Scm and trapezius both do this action of moving the canines and moving with the jaw, ripping at things. It's an extremely important muscle. Matter of fact, why would nature and God devote one cranial nerve to these two muscles? So the 11th cranial nerve, the accessory, it controls just these two muscles, the trapezius and the sternocleidomastoid. So they must be important. The insertion of this Scm, sternocleidomastoid, is on the mastoid process. And again, it's one of those muscles that seems to be involved in almost all Tmd patients. And it basically creates havoc. First of all, if a person has tendinitis of the sternocleidomastoid, there's going to be pain in the mastoid area. And I hope and pray that that's not confused as mastoiditis, because I have seen patients come in with Tmd problems, having, Scm tendinosis, and had previously an operation in that area. But the Scm attaches to behind and below the ear. Isn't that interesting? Now, the middle portion of this muscle is interesting because, as we previously mentioned, the head orients with the eyes and the vestibular apparatus on both sides. Then the body has to move itself to adapt to where the head is. The body itself doesn't have a vestibular function. So the Scm is one of those muscles, probably one of the primary ones, that will orient the head. So if a person has a forward head posture, trying to avoid the temporomandibular joint, which is universal, they're going to start seeing some crazy stuff. And you can also see that just anterior to the Scm is the Stylo hyoideus, is a posterior digastric, again, posterior digastric 7, Stylo hyoideus is also 7, but it attaches to the base of the tongue, to the hyoid. But it is optional. You could look at this. The actual, very interesting, I should mention that in some patients, if you compress at the sternoclavicular origin, they'll start coughing. It's amazing. It's kind of, unfortunately, I've thought it's cute sometimes, so I'll keep on doing it, and my assistant will say, stop that, you know. But it is so interesting that when I compress on that anterior, that origin, they start coughing. So you have a patient coming in coughing a lot, it is possible that that is part of the problem. So it is optional. Many temporomandibular patients also have sternocleidomastoid muscle involvement, and it can be palpated immediately behind the ear in the mastoid insertion and along the length of the muscle to the sternoclavicular origin. Now, involvement of the middle portion of the SCM can cause dizziness and vertigo, mimicking vestibular dysfunction. And so this is a critical factor because it isn't always an otolith. You've got to evaluate the patient. Also, if you send a patient off of physical therapy for vestibular treatment, please have them come back again and see if it worked. If it didn't work, it's very possible it wasn't it. And usually, if a treatment doesn't work, you learn to diagnose by treatment failure sometimes. You put an antibiotic, it doesn't work. It may not be infection of that spectrum. So you need to have them come back again and see if they still have that vestibular problem. And the middle portion of the SCM, when compressed with a pincer type motion, can sometimes cause the patient to get very dizzy. So that's important because what are you going to refer out for head and neck or cervical manual therapy, or are you going to refer out for vestibular therapy to the PT? They're two different things. I had the experience of going into a PT area one time. The attending physician had sent the patient in for vestibular therapy, and she obviously had a huge neck, probably a sleep problem, canted forward. You knew there was an SCM problem. And I walked over and palpated the middle. The patient almost dropped to the ground. And I asked her, are you ringing? And are you getting dizzy when I did that? And she said, yeah. And I walked away, and the physical therapist just continued with the tinnitus, with the vestibular therapy, even though it was very clear in front of her that that wasn't the issue. But it is, you want to be sure that your vestibular therapy works before you dismiss the patient. Your patient should come back for a re-evaluation, and you need to work with the PT and ask the PT to evaluate the cervical musculature. This is a pain diagram related to this sternocleidomastoid, and I thought I would show it to you to spend even a little more time because it does involve ENT and it does involve TMD. So you can look at the right diagram, and the first thing that you're probably looking at the ear, but I'm looking at that forehead. So frontal sinus pain can be misdiagnosed by pain referred to the forehead by the sternocleidomastoid muscle. The middle dot on the right diagram on that SCM will cause forehead pain. And it's both sides. It's bilateral. This is extremely interesting to me because neurologically we know that there's no such thing as referring to the opposing side. But this muscle does it, and I believe it's the only structure in the body that refers to the opposing side. And there's lots of explanations, things that can be talked about. But forehead pain, both sides, patient takes his finger and goes back and forth. Does it go right to the center where the frontal sinus is? This might be the SCM. And you'll notice also ear pain. So we got ear pain and slightly superior to the mastoid area, pain. But this is you again. Ear pain. Oh, don't know what it is. Could be from the superior aspect, the upper dot, into the ear referred pain. If you look at the left diagram, different portion. This is the sternal division. The right diagram is the clavicular division. This is interesting too, because one, look, you got pain at the base of the throat, right above the clavicle and sternum, and you get pain in the throat, see right below the jaw. So a person comes in with throat pain, deep throat pain, and you're like, oh, I don't know, everything looks good. You're fine. You're a malingerer. No, it could be this muscle creating this particular problem. The pain also goes over the joint. If you look at that left diagram, pre-articular pain can be caused by the SCM, and it goes up and around the top of the eye. Again, frontal confusion, and goes downward between the eye and the nose. Pain between the eye and the nose could be pain-related SCM. So they go to the ophthalmologist, pain behind the eye, rules out any intracranial disease or eye function. They send it to you because now they know that this is the nose, and you look at this and you say, do you have pain, near your joint, behind your eye, back of your neck, and your ear? Oh, yes, yes, yes. You diagnosed the cause of this. So it doesn't have to be contact point pain. It could be the SCM. Muscle referral is pain referral from muscles is extremely common. We've mentioned that several times, but I think it's particularly important to mention the Splenous Cervicus. This is a posterior neck muscle. So if you have a forward head posture with a mouth breather, this muscle is trying to pull that neck back so the head doesn't fall over. And when this muscle is overworked, it develops trigger points and causes pain behind the eye on the ipsilateral side, almost always diagnosed as ocular migraine. And it is highly associated with joint problems, interarticular joint problems, with the disc itself being unstable. There's a direct correlation between pain behind the ipsilateral eye of a TM joint that doesn't function well. So pain extending from the eye along the side of the head through the ear, and all the way to the back of the head is caused by spinous capitis trigger points. So I can present with ear pain. You ask them, do you have pain behind your eye? I'm going to say probably maybe 40% of them are going to say yes. And then you possibly could probably hear some clicking and popping on that side also. So pain in the ipsilateral ear, pain behind the eye ipsilaterally, clicking on the ipsilateral jaw joint. These are all related to a complex of things. And again, who said it was going to be all easy? It's not. Pain in the ipsilateral angle of the neck is also very, very common. One of the interesting things is the tensor tympani and the medial pterygoid are intimately related from their common phylogenetic and embryological relationships. They're interconnected. The medial pterygoid muscle and the tensor tympani muscle are both innervated by the same nerve, the pterygoid branch of the third division of the cranial nerve 5, C5, third division. Irritating influences upon either muscle could potentially affect the other muscle. Shortening of the tensor tympani muffles hearing by inhibiting the vibration of the eardrum. It can also cause tinnitus if it's spasming. Shortening of the medial pterygoid limits mandibular opening. So the medial pterygoid is a closer elevator, and if it's in spasm, it's going to shorten. And when it does shorten, it drives the mandibular condyle up and back onto the sensitive intracapsular retrodiscal tissues. And isn't this what Costin spoke about? So also note that the tensor tympani is related to the tensor villi palatini. They're integrated if you look at their origins and their connections. So this is very interesting. And in the diagram, they call the medial pterygoid a deep muscle, which is inside the mouth. You've got to put your finger back in the throat, downward, behind the teeth, at the angle of the jaw, and compress inward. So it's an internal muscle, and another name for the medial pterygoid is the internal pterygoid, or pterygoideus internus, the Latin name. I am always completely amazed when I see beautiful things happen in nature. Uh, the human swallow is one of the most amazing things. It is just a perfect symphony of movement with multiple nerves all coordinated together, very much like a symphony orchestra with each one of the instruments playing at the correct time, at the correct amount, all beautifully coordinated. And let's look at the levator palatini, tensor veli palatini, eustachian tube, and the bruxism, dental bruxism. So when I see dental bruxism, this is something that I'm going to observe, and we're going to go over this phenomenon. So when the tensor veli palatini and the levator veli palatini contract, and the salpingopharyngeus also, during swallowing, they pull the soft palate upward to avoid food getting into the nasal cavity. They slam the soft palate up against the bottom of the nasopharynx to seal it. Simultaneously, at their origins, the tensor veli palatini and the levator veli palatini open the eustachian tube, since there's little chance of food entering into the tube when the soft palate closes the nasopharynx. I think this is amazing, right? It's all beautifully coordinated, and this is where you aerate your middle ear by swallowing. So a person that is just compulsively swallowing, grinding their teeth, they're trying to open their eustachian tube very often. In order for the tensor veli palatini and the levator veli palatini to contract, the teeth must be a maximum intercuspation to provide a mandibular platform for raising the pharynx. So let's talk about this just briefly. The hyoid bone is suspended mostly off of the mandible. Of course, you've got the stylo hyoid ligament, and there are structures and soft tissue connections, but the basically you can think of the mandible suspending it, moving when the mandible goes forward, pulls the pharynx forward, backward, upward. And in order for the swallow to occur and the pharynx to be raised upward during the swallow, the mandible has to be fixated against the opposing teeth. And that way you can pull the pharynx up. If the mandible was loose as a goose, it would pull the jaw open. And the jaw does not open when people swallow in a normal individual. So this whole mechanism of swallowing becomes abnormal if there is a eustachian tube blockage. So if you have allergies or any problem that could irritate the eustachian tube opening or constrict the opening, let's say due to allergies, the child or adult is going to try to brux, pull their teeth together, swallow, pull the teeth together in order to slam the soft palate up in an attempt to open the eustachian tube. This is why we see very often pediatric grinding. Pediatric bruxism can be pretty loud. Mothers will often complain of it, and it seems to often accompany ear infections or allergies. So it's something you should be looking at. There is a book that was written called The Stigmata of Respiratory Allergies by Meyer Marks, a pediatric allergist at Miami. And it's just an interesting text that shows how the interrelationship between breathing, swallowing, all the functions of the upper respiratory system seem to affect the teeth and tissues and all sorts of stuff. I do have a copy of that if you want it in PDF. I continue to discuss this tensor veli palatini problem from swallowing. It closes the soft palate, opens the eustachian tube. So if a kid has a eustachian tube problem, or an adult, they're going to try to tense this muscle in order to open the eustachian tube. It will end up creating all kinds of problems. So the continued contraction of the tensor veli palatini in an attempt to open the eustachian tube, the tensor veli is innervated by the trigeminal nerve, my nerve, the dental nerve, the one that I oversee, can cause pain in the throat emanating from this muscle's bursa at the hamular process of the pterygoid bone. Palpation of the tensor villi palatinis bursa behind the maxillary tuberosity verifies that this throat pain originates from this muscle. Now, a plastic skull is very nice to have because you can see the anatomy back there, you know. So where is this bursa? All right, so first of all, the bursa is posterior to the hard palate. And you follow the row of teeth on the side that you're investigating, goes back to the tuberosity, which is like a tuber, which is like a potato, big round thing. And then on the medial aspect of the tuberosity is where that pterygoid hamulus is. And if you apply pressure slightly behind there and up, and the patient hurts, the throat pain is coming from that bursa. Why? Because that bursa is being overused in an attempt to open the eustachian tube. They're constantly grinding. And get this, people who brush their teeth, adults who have TMD problems and brush their teeth, that's a temporomandibular sinus symptom. They will have this type of throat pain also. And very often it just goes undiagnosed. I'm going to spend just a little bit more time on this tensor villi palatini bursitis. The pathology of the tensor villi palatini can cause throat pain. This is your area. Most commonly, the pain is due to tensor villi palatini bursitis. The bursa is a little slippy slidey tube that a tendon goes through. And if it gets dry or if it's worn down, it gets inflamed and can start hurting. And why would it happen? When there's just lots of problems with trying to open the eustachian tube. The tensor villi palatini has a bursa located at the pterygoid hamulus, which can become inflamed, not the hamulus. Well, the hamulus could too, but bursa can be more likely due to excessive use of this muscle. The hamulus is easily palpable immediately behind the posterior aspect of the maxillary tuberosity. The etiology of the pain is secondary to excessive function of the muscle in an attempt to raise the soft palate. And this etiology should always be addressed first before performing any invasive surgical procedures. And like things like Eagle syndrome, which is really rare. I mean, we talk about it a lot because it's an interesting phenomenon, but it's usually going to be this, not Eagle syndrome. And then Eagle syndrome has a specific set of diagnoses that should be adhered to, but that's not the topic here. We're screening for TMDs. But there are other things, superior constrictor syndrome, hyoid syndrome, other various things that I get involved in, and it would be good for you to know these, but that's not, again, TMD. It is more orofacial pain. There is often a ligament extending from the posterior aspect of the temporomandibular disc, which traverses the pterygomandibular fissure and enters the middle ear to attach to the anterior aspect of the malleus. It's called the discomallear ligament or Pinto's ligament, although this ligament is not present in all humans, or at least they can't find it during dissections. There are documented records of arthroscopic procedures within the temporomandibular joint, which have caused tearing of the eardrum, despite the oral surgeon never entering the middle ear. These surgical mishaps conclusively prove the existence of the ligament in many patients. This is a dissection quite nicely illustrated, taken and labeled of the discomallear ligament. It exists. Dysfunction of the temporomandibular articular disc could potentially cause ear symptoms since the articular disc is tethered to the malleus. This could be a potential problem upon opening the mouth wide, since this movement pulls the articular disc forward, tightens the discomallear ligament, thereby distracting the malleus, freezing the ossicular chain. So if the ear symptom changes with mouth opening and closing, then we know that it's related to this ligament. Interestingly, there are connections between the ear and the inner ear, not inner ear, middle ear and the jaw. And you just put your teeth together, and gently swallow and listen to your ear pop. This is an interesting diagram, and it shows the relationship between the discomallear ligament and the sphenomandibular ligament. Both of these are embryologically connected, and notice they both attach to the same spot on the malleus. Interestingly, also, the ventral center rotation of the mandible during all motions is at the insertion of the sphenomandibular ligament at the lingula of the mandible. The origin of the same ligament attaches to the malleus. And center rotation has to do with the position of rotation, ideal rotation. So the mandible rotates open for the first 25 millimeters, and then it impinges on the neck, which would impair breathing, swallowing. So then nature and God caused the mandible to translate forward, actually slide forward. The sliding motion is not a rotation, but if you look at the net A to B from start to finish, the center rotation is always on a line at the lingula of the mandible. So dysfunctions of the mandible will cause very often sphenomandibular ligament dysfunctions. Ernest syndrome is insertion tendinosis of the stylomandibular ligament. The stylomandibular ligament is a skeletal ligament which stabilizes the temporomandibular joints and helps guide the joint and mandible through the mandible's normal range of motion. The stylomandibular ligament's function is specifically to limit opening and protrusion of the mandible. Primary symptoms are 1. Pain in and around the TMJ, which causes a referral to an orofacial specialist, Tmd specialist. 2. Ear pain and ear fullness, to you. 3. Anterior temporal pain and headache, Tmd specialist or neurologist. 4. Pain in the body of the mandible, dentist. 5. Eye pain, and 6. Throat pain. So 2 of the symptoms, 2 and 6, ear pain and ear fullness and throat pain, can be a reason for them presenting to you, and there's no reason, there is no pathology within the ear itself. There is a relationship between obstructive sleep apnea and TMD. If you think of the pharynx as being a flexible open tube suspended by the hyoid bone and the mandible, then you have a situation where it opens and closes based on the movement of the hyoid and the mandible. In turn, the hyoid bone is superiorly suspended by the mandible via the mylohyoid, genohyoid, digastric, and hyoglossus. When a person lays supine and the jaw falls backward because that's its normal position, it's going to collapse the airway. There's no tonus in the muscles. And this is something Costin knew about. As Costin stated, the mandible is displaced posteriorly in temporomandibular disorders, which collapses the airway posteriorly. This is the same phenomenon. As we reviewed, the structures of the pharynx are suspended primarily by the mandible. And you can see this person in a supine position. The tongue is hitting into the back of the oropharynx. The soft palate is down, blocking ear inward. This is an interesting thing. I believe strongly that obstructive sleep apnea has a lot to do with the retropositioning of the mandible, which is extremely common and almost always present with patients that have sleep apnea. Now, sleep apnea appliances, dental appliances, almost always anteriorly reposition the mandible and fix it there during sleep, and that prevents the airway from falling backward. So you can think of the pharynx as being a flexible open tube suspended by the hyoid bone. In turn, the hyoid bone is superiorly suspended by the mandible via the mylohyoid, geniohyoid, digastric, and hyoglossus. And again, as Costin stated, the mandible is displaced posterior in temporomandibular disorders or Costin syndrome. It isn't a syndrome, so that's an old term, but we do hear some ENTs using it. And that posterior positioning of the temporomandibular joints and mandible collapses the airway. And it's extremely important to understand that there are alternatives also to CPAP, which I think there's only a 25% full compliance. So TMD, sleep apnea, obstructive sleep apnea are related. So we do find a great many TMD patients having sleep apnea. So there is a link between temporomandibular disorders and obstructive sleep apnea because the mandible is dysfunctioning. What is really interesting to me is that the American Academy of Sleep Medicine, which is a physician's organization, has recommended dental sleep appliances for mild and moderate obstructive sleep apnea. But physicians are not dentists. So most patients get placed on CPAP instead of receiving much less intrusive oral appliances. As I've said, there is a link between temporomandibular disorders and obstructive sleep apnea. And again, it's just anatomical if you think about it. If the mandible is displaced posteriorly, person has a very small mandible, plus it is literally positioned posteriorly. The tongue, therefore, the genioglossus won't pull it forward. Pull the tongue forward, tongue's going to be in the way. There is a link between temporomandibular disorders and obstructive sleep apnea. Now, what's really incredible is the American Academy of Sleep Medicine has recommended dental sleep appliances for mild and moderate obstructive sleep apnea. But because physicians are not dentists, most patients are placed on CPAP, and they say, when you speak with them, this is the gold standard, but that's not what the recommendation is. So instead of receiving a much less intrusive and less costly oral appliance, they get the CPAP because that's what the sleep physician is familiar with, and honestly, that's what they sell. That's what they do. They don't make oral appliances, but their academy has stated that oral appliances are effective. So we have several different types of oral appliances shown here. Of course, dentists are experts at making oral appliances, and you should consult a dentist, particularly someone trained in sleep apnea. And the Tmd Institute does sleep medicine. Unfortunately, in the state of Georgia, unlike most other states, dentists are not able to run sleep tests. We can interpret them and be trained in them as I am, but we can't run a sleep test. So we are even more dependent on ENTs that are interested in sleep. I think before I start talking about nasal oral co-development, I need to introduce you to a PhD, I believe it's at Columbia, but his name is Melvin Moss, and he developed the functional matrix theory, which states the origin, development, and maintenance of all skeletal units are secondary, compensatory, and mechanically obligatory responses to temporally and operationally prior demands of related functional matrices. Function meaning doing things. So the entire oral apparatus grows secondary to the tongue pushing everything out and down, and the cheeks, the buccinator muscle, masseter muscle pulling things in, and all of the movable, stretchable tissues that place forces upon the bone. It's extremely important. And I think about this almost on a daily basis when I'm seeing patients, and I always say, well, how did this dental arrangement, nasal arrangement come about? What is it? I think the proof of the pudding here is we can see what happens when you apply continuous forces to bone over time. And so why are we showing you this skull and this neck is because we're about to be introduced to nasal development through the oral cavity. And the nasal development is dependent upon oral cavity development. Basically, Dr. Moss was basically elucidating something having to do with the physiology of bone. And Wolff, a physician and researcher, Wolff's law of bone states that bone in a healthy person or animal will adapt to the loads under which it is placed. If loading on a particular bone increases, the bone will remodel itself over time to become stronger to resist this sort of loading. The internal architecture of the trabeculi undergoes adaptive changes, followed by secondary changes to the external cortical portion of the bone, perhaps becoming thicker as a result. In other words, form and function have a great deal to do with each other when it comes to bone. We're just talking about bone right now as one tissue. And again, bone is the supporting architecture of the nasal complex and the oral complex. You continually in undergraduate studies, and we should never trash our undergraduate studies. It taught us to be scientists. And we need to go back now that we're done with our medical dental studies and look at the basic physiology, the basic chemistry, all the origins of the things that we're dealing with. That gives us a godly approach, at least one that allows us to look at the etiology of things. And we should always be doing that. And be careful when we get into protocols. We should always say, what caused this problem? But throughout my biochemistry education, we always had this term, form follows function, and I thought this was a term coined by a biologist, but in fact, it isn't. It was termed by Lewis Henry Sullivan, and he was the guy that built the first skyscrapers in Chicago. So form follows function, function determines morphology. Oh my Lord, now we're talking about a lot of different relations here in terms of the development also. Now if we look at oral nasal co-development and start thinking about things, on how things happen, it's extremely important. I think the first thing to note is that the nose has no moving parts. There's no internal muscles, right? So what is causing the development? The growth, is it just genetic? Well, that's Moss tells us that that is not just genetic, that there's a functional matrix related to the nose. So muscles and soft tissues guide the oronasal growth. Much has been written on the subject, and again, we just mentioned Melvin Moss, who elucidated the functional matrix theory of growth and development. So in a nutshell, when the patient swallows, which happens 60 times a hour, the tongue pushes up onto the hard palate and applies upward, lateralward, backward, and anterior pressures to that hard palate. It expands the hard palate outward, and it drops the nasal vault of the oral vault, right? The palatal vault. Wait a minute. When you drop the palatal vault, you're dropping the nasal complex, right? And the nasal septum is being stretched downward. So the lateral tongue pressure also expands the alveolar process laterally and naturally develops a lateral width. If someone's a mouth breather, they're not swallowing because their mouth is being forced to stay down like a panting dog. So with correct swallow, we see the palatal vault dropping downward and flattening, pulling down the bottom of the nose, widening the spinuses, widening the base of the triangle of the nose. Everything's getting bigger because of correct breathing and correct breathing, nasal breathing. So when you have abnormal tongue function, you're going to have abnormal growth and development. We know that. We've talked about that. some critical anatomical features. We said, well, gee, the temporal bone houses the TMJ and also the ear. Oh, Lord. But also, we get another connection that the floor, we have all these direct anatomical connections. The floor of the nose is the roof of the mouth. So lateral palatal development extends the nasal septum downward, widens the floor of the nose, increases nasal volume, decreases airway resistance, and increases lateral width and height of both maxillary sinuses. So there's not going to be this clumping and problems in the osteomeatal complex. There's more room there to function. It's an interesting concept, integrating oral development and nasal development, and I'm hoping that this will grab your attention. If we look at just a diagram of the skull anteriorly and left, the eyes, the nose is a triangular area, maxillary sinus is right and left. Now below the nose is the tongue, all right? And the tongue pushes outward every time it swallows, and it does that 60 times an hour. You can't really see it, but below the sinuses is the teeth and the alveolar processes. I have a diagram of a planar straight, it's a two-dimensional diagram of a three-dimensional thing. As the arrows to the right, the tongue compresses everything out, the palate drops. Do you see the arrow going down? So does the septum drop going down. So the base of the nose is going to get bigger. The maxillary sinuses are going to get laterally and vertically bigger. There's going to be more room in the osteomeatal complex. You're going to have less problems. There'll be more room for the turbinates. Everything's lovely. The floor of the nose is the roof of the mouth. So lateral palatal development extends the nasal septum downward, widens the floor of the nose, increases nasal volume, decreases airway resistance, and increases the lateral width and height of both maxillary sinuses. So it's interesting, in underdeveloped nasal areas and underdeveloped mouths, you're doing surgery to kind of fit it into the abnormal three-dimensional structure that's there. And it's really interesting. We said, well, why are we having so many of these problems? Why do we have so many nasal problems, allergy problems? These are questions that should be critical. But this is one of the reasons why there is compaction in that nose. It's not as big as it should be. You can look at skulls also of our ancient ancestors, and it kind of reflects this. And I'm going to go to the next slide with a little bit more of a diagram to talk about. And this is a little bit, again, diagrammatic, but you'll notice the dots on the side of the nose going down and out. So the nose is actually going to get bigger. Nose 2 is the bigger triangle. The apex is the same, but the base is much bigger and wider. This also occurs with the maxillary sinuses, right and left. They're bigger. And it may be one of the reasons why we have changes in tonality as we develop. But there's a wider base, the septum gets pulled downward, and there's just way more nasal volume. And this is kind of critical, and we don't really think about it. And here it is. It's like your daily practice, probably mostly adults. And so you're not thinking, well, wait a minute, what I do might affect kids. And we probably need to be thinking more about this. I know in the earlier years, people did a lot of tonsils and adenoidectomies, TNAs, and they were important because we had almost universally kids blocked out. Then they said, well, no, that's tonsillar tissue, and that you should leave that alone. I mean, that's allogenic tissue. It's lymphoid tissue. Leave it alone. And now you don't do these things, and we're seeing developmental problems, facial distortions, dental problems, TMD. This is all related. We're correlated. What you do and I do are integrated. Mouth breathing is devastating. I mean, I can just sit at least an hour, maybe two, on the consequences of mouth breathing. There have been studies done with monkeys where they've obstructed the nose, and it completely distorts the orofacial complex. So you guys, you ENTs, you are essential because mouth breathing typically occurs secondary to nasal obstruction. And not, we usually think of tonsils and adenoids, but let me tell you, those turbinates are a problem on adult patients. I read panoramic x-rays every day, and I see turbinate hypertrophy in, I'm going to say, 60% of my TMD patients. And they also have sleep problems. Why? They're breathing through their mouth and snoring at night, and they tend to have low energy when they wake up in the day, and they eat high carb diets to get the energy, and their BMI goes up. But the clinical consequences of nasal obstruction and mouth breathing are amazing. Humans oxygenate their respiratory alveoli during exhalation, which is interesting, because as they exhale, there is an obstruction, the nose, and if the mouth is closed. So the nasal valves restrict the flow of air out of the nose and thereby increase the pressure in the airway upon exhalation. Proper nasal valve function is critical to correct breathing, and you have to have an open nose also for the air to get out, not just in. We tend to think breathing in is hypercritical, but breathing out is critical for PO2. Increased airway pressure then provides increased PO2, and the air passes into the alveolar capillaries. Mouth breathing from nasal obstruction causes numerous growth and development problems, dental development problems, hypooxygenation, deviant swallowing, narrow maxillary arch wisps, adenoid fasces, and in most cases, a forward head posture. This is just the beginning of a list of harmful consequences that you guys are important in preventing, except that pediatricians tend to be very conservative in managing their kids, and they don't often refer to an ENT. And I wish they did, and I wish ENTs would get involved in allergies because that's primarily the etiology of allergic rhinitis, I mean, in most cases. So, and swelling and turbinate hypertrophy. So close cooperation between dentists and ENTs is essential to airway management and orofacial growth. So we're looking at malocclusions secondary to nasal problems. And it's extremely common, but again, the orthodontic community tends not to be integrative with ENTs or allergists as much as they really should. These are two photographs and illustrations taken from two separate areas. One is the left, and let me tell you, Meyer Marks wrote a scope publication, which is no longer available, but I have PDF copies if you're interested, because it just blew me away. I received a copy of this from a friend in like 1986, and it just showed me the consequences of allergenic problems in children and their growth and development. Meyer Marks was a pediatric allergist with the University of Miami, and he wrote the scope publication, Allergy, the Stigmata of Allergy. But he has a illustration here to the left, which blows me away. This is what people with children with allergies have. They have buck teeth, narrow upper jaws, and Dr. Marks is illustrating this in his textbook of allergies, pediatric allergies. So, nasal allergies, let me tell you, can create a lot of problems because, of course, the consequences of this maldevelopment is allergy creating airway problems. On the right side are rhesus monkeys, and a researcher amazingly put Teflon plugs in monkeys' noses to see what would happen to their faces in a situation where they couldn't breathe through their nose. And if you look on that middle picture, it's buck teeth. And that's what happens. There's a whole things that happen. Adenoid Fascism comes from this type of development. He confirmed this. So this is like experimental evidence that nasal obstruction causes dental malformation. And so we need you guys, right? And again, there needs to be integration between allergists, dentists, and ENTs. It's always wonderful when we get an ENT that's interested in allergy and also sleep, because we're all integrating right now. This is the cover of the scope publication that I was referring to. Left, Stigmata of Respiratory Allergies, a scope publication. Years ago, Scope used to publish these and distribute them, Upjohn did, to physicians for free, and really nice nutshell stuff. The right side's a little more fancy, later edition, a lot less though. You can't find that. You'll find the left side. These are rare. I do have PDF of this particular book simply because I tried to contact Upjohn and Scope and tried to get permission, but it's out of date, expired, goes back a long time ago. So I just scanned it into PDF so that I can have my residents look at it. And so if you wish a copy of this, I can get it to you in PDF form, but it is a worthwhile read. I think that a physician, a dentist, anybody in the clinical practices and helping people, more so dentists than physicians. So, I mean, we tend to be so focused on teeth, we forget all the other things that are surrounding this human being. And I'm hoping when you see patients that you also take a look at them. It was a pretty famous, I wish I could go back and find out where I heard this, but there was an old, very famous English physician, and a patient was brought up onto a stage at a hospital for clinical rounds. And this physician looked at this patient and amazed the other physicians, because he said, well, number one, he has damage in his right hip. I could see that by the limping to one side. And I also saw how his foot hits and strikes. Then it's probably from coal mining, because I looked at his shoes and there is coal dust around there. And then he's an alcoholic. He made that statement. And everybody says, how do you know that? We said, well, there's the flask in the right pocket. So the physician took a look, and this is kind of a critical thing. Look at your patients. And this is adenoid fasces. and we'll take a look. He's a critical thing. One, his mouth is open, right? He's breathing through his mouth. He is a mouth breather. Little tiny nostrils, no development of that nose. The base didn't get wider, and there's no tiny little nostrils. He has braces on because he has a malocclusion, and that's related to the nose, isn't it? Look at the eyes. The left eye is higher than the right. That left eye never descended downward, so isn't the ear. Temporal bone is higher. Look at the chin button. It's off to the left. This kid has a torqued mandible, guess what? Going into the ear, causing later a TMD problem. Profile, no jaw. That jaw should be below the middle. If you bisect the nose, and drop a line straight down, chin should be right on that. He's also forward, and he doesn't have any malar processes. This is called adenoid fasces. And if you look at Meyer Marx's book earlier, this is not taken from his book, but he goes over allergic shiners, a crease in the nose from constant allergic saluting. So these are things you should look at because this kid is a future problem. We see TMD more in females because their tissues are softer. They don't have testosterone making them thicker tissues, more load-bearing tissues. But take a look at your patients. This is a pretty good example of adenoid fasces. This kid is probably going to fail with orthodontically. He needs a TNA, and this is important. That's extremely important because what's going to happen is take the braces off and all those functional problems related to the mouth still going to be there and distort him. I'm just going to briefly review from that original diagram, the kidney fund diagram, the throat symptoms. 1, swallowing difficulties. Swallowing is a muscular action that requires muscles to be in resting normally and functioning normally. And if you have everything positioned incorrectly, the muscles have to compensate to hold things in place. So if you just bend down a little bit, go into a squat, try to keep that for 2 days, you're not going to function. Your muscles are not going to function correctly. So when you have a TMD problem, often the mandible is in the wrong position and you start having muscle length changes and muscles supporting the whole head and neck apparatus when it should be bone. Laryngitis, well, the air goes through the larynx, and it also is affected because the larynx is suspended by the mandible, and when the mandible is posterior, you have compression of elements around the larynx, and then also dysfunction. Sometimes when muscles are not at their right length, they have to hyperfunction to do their job. They have to be modified to do their job. Other accessory muscles have to be brought into play. This is true with with breathing. If some patients can't diaphragmatically breathe well, then the upper chest muscles have to kick in and they start functioning even though they're not meant to do that full time. They can do it, they're accessory, but you can start seeing pain in the upper quarter just from incorrect breathing. Sore throat could be simply, again, muscular pain in that region, voice irregularities, the larynx is not functioning well. Coughing due to irritation, compression of the throat, tissues that touch more often than they're supposed to because it's collapsing, throat pain, and very often, it's very interesting, a feeling of an object stuck in the throat. We had a faculty member of a medical university bring his daughter in, and from what? A feeling of an object stuck in the throat. And I think that you should know about this. I think you should know that's can be related to TMD because patients are going to get real worried when you don't know what's causing that throat problem. But these are some of the symptoms that we see, throat symptoms, and some of their etiologies and quick review related to that. There is an incredible host of ear and jaw integration problems. Why? Because they are related phylogenetically, embryologically. They're just all, we're all tied in. Ringing and buzzing. Well, that could be from the tensor tympani dysfunction due to um, the uh, the medial pterygoid dysfunctioning, same nerve. Could be the the Pintos ligament's not functioning. It's pulling on the malleus all the time. Uh, muscles go into spasm, don't they, sometimes? When they spasm, they're going to cause that ringing because there's a pulling in electrical signaling also. So there's a lot of reasons for an integration between hearing. Decreased hearing, well, it could be simply that you have a tense tensor tympani muscle. It could be that the discomalleal ligament is pulling on the malleus so that the tympanic membrane is not moving well. And a lot of ear pain, that could be from referral from muscles in the area which are trying to compensate. Cloggy, itching ears, ears that have a lot of earwax, that's something we see all the time. It's really interesting. And I just think it's just irritation of the canal, sometimes from the posterior dislocation of the condyle on the external auditory meatus or on the soft tissues. And vertigo and dizziness, well, we discussed that. We discussed it primarily, I think that comes from sternocleidomastoid problems, but you can also have relationships in circulation of blood to the inner ear, secondary to TMD problems. So we can get real complicated because sometimes weird things happen to TMD patients. They get better, and we don't know why. I mean, we just have no idea why. I've had a couple of patients who were infertile that got pregnant. Now, what is that? I'm not claiming that, but I've seen it. Well, maybe because it's causing lots of stress. And once we take care of that head, neck, facial pain, they feel better, they function better, they go back into circadian rhythm, their endocrine system works better. Who knows? But I know that we get all these interactions which are extremely common. So never assume, let's say, that pulsatile tinnitus is due to an inner ear problem only. It could be the medial pterygoid is dysfunctioning in spasm, which is the nerve to the tensor tympani, and that goes into spasm. So it's ringing, and really what it is, that oral muscle, that muscle of mastication is what the problem is because of the joint. There are interesting things that happen and we can get into it developmentally or neurologically or vascularly, things like rhinorrhea. What is that about? Well, rhinorrhea can occur from autonomic dysfunction, get this, from pain or from muscle referral. Muscle pain from trigger point referrals can have autonomic components. So you're wondering what this rhinorrhea is, and it might be related to a TMD problem. But you see a deviated septum. We went over the development. Narrow maxillary sinuses with obstructive osteomeatal complexes. Narrow nose basis. We went over all of that. And this is related. The TMD is a consequence of this developmental problem. But the nasal symptoms also a consequence of the developmental problem. So they're all related. So if I see dental malformations, most often I'm seeing nasal malformations also. And for me, just to treat like the orthodontically treat the bones and the teeth, then I think that is not appropriate. That should be more comprehensive and work also with the ENT to get that airway open. But there are no symptoms. I see a very high percentage of sleep problems in TMD patients. I'm going to venture to say that it's probably 50%. And I'm going to tell you crazily that many, if not most, of those patients get better without having a CPAP or without having even a dental appliance or a sleep apnea appliance. Very interesting. But people with TMD and obstructive sleep apnea, both, very common, often have temporomandibular joint pain. If they wear a CPAP, that CPAP seals on the mouth and pushes the mandible backward, hits against the ear and can cause existing TMD problems to get worse, or patients that don't have TMD for it to develop. Ear pain, very, very common. Nasal obstruction. This is a key point. Pulmonologists deal with very sick people typically, but they very often are the people doing the sleep studies. And there are now sleep specialists, physicians, but they have very little ENT training. So what do they prescribe? CPAP for everyone. But what happens if there's turbinate hypertrophy and fibrosis and mouth breathing, and these people can't breathe through their nose? And you can see this, even dentists are very neglectful because we do not always read our panoramic x-rays because it can be clear that there's no nasal airway opening. So in the panoramic, but they'll place a CPAP on a patient who can't breathe. So it's pushing air through a blocked nasal apparatus. Very common. I see this a lot. And what's the compliance rate for CPAP? 25%. So why? Because if you ask the pulmonologist, did he evaluate the nasal area? Did he go back and do a study with the CPAP? And the answer almost always is no. Insurance doesn't like that. So other things we see, severe bruxism, particularly in male patients who are sleep apnea patients, underdeveloped maxillas, underdeveloped mandibles. They snore. And dentists, I mean, there was a period of time before the sleep apnea, obstructive sleep apnea became well known in the dental profession. We were doing a lot of snoring appliances when these people had some serious problems. And we were just pulling back the soft palate to prevent it from vibrating, when in fact that was probably making it worse, the obstructive sleep apnea worse. We don't do that anymore. I pray we don't do it, but we used to. They have patients who have TMD have pain and they have disturbed sleep, and people that have obstructive sleep apnea can't get oxygen. They have these hypopneic and apneic events, and they just can't sleep, and it makes the TMD worse, and it makes the obstructive sleep apnea worse. Everything's worse. Head pain, migraine. Seen patients who previously had a lot of headache. We treat the TMD, the migraine goes away. But not always. Please don't say I said that that's a cure. I said there is a subset. But enlarged tongues in their Malpetty score show that they have no airway in the back of there. They open and you can't intubate these people, right? They have enlarged necks because they're breathing through their neck. Their accessory muscles of respiration are breathing through their neck. And metabolic syndrome, which causes central obesity, causes high lipids, elevated sugars, but not diabetic, just low HDL, and high blood pressure. So when we see high blood pressure, you should look, is this guy or lady obese? Whoa, maybe it's metabolic syndrome. Could be possible that they also have a TMD problem. It's very commonly associated with it for various reasons. But you see someone heavy walk in, like who's an apple, you should be thinking, you're a physician, you should not just be thinking ENT, you should be saying, well, oh, maybe he has metabolic syndrome. Very easy to cure that, not cure it, but let's get them on a low carbohydrate diet. There's paper after paper after paper showing that. But there's an integration again that we see, and you particularly should be looking at patients that have obstructive sleep apnea, which is common in TMD. Why? Because CPAP's not going to work. And in fact, I think earlier in the video, we said mild or moderate sleep apnea, obstructive sleep apnea is best treated with an oral appliance. How often does a pulmonologist prescribe an oral appliance? I'm not going to answer that question because it's usually when someone is really in trouble, but it's not common because they're not looking at the nose, they're not looking at the mandible. But this is something that you should take some time to become attuned with.
Functional symptoms, such as clicking and locking, are some of the most frequent findings in patients with temporomandibular joint disorders. Both the normal and pathological anatomy and function of this joint has caused a lot of speculations. Can you, Dr. Eriksson, review the anatomy of a temporomandibular joint?
This is a sagittal section of a right temporomandibular joint. Here you can see the condyle, the fossa and the tubercle. This is a disc. And here you have the upper joint compartment and the lower joint compartment, filled with blow water in order to stabilize the disc during sectioning. The soft tissue cover on the condyle is thin. This is probably an artifact. And it's also thin in the fossa and somewhat thicker on the tubercle. The posterior band of the disc is situated superior to the condyle. The posterior attachment is a little bit thinner and longer than seen in an absolutely normal joint. The lower head of the lateral pterygoid muscle is seen here, and this is the superior head. The knowledge of anatomy is essential for understanding of joint pathology. During arthrography, we have learned that the function of the joint is also very essential. Which are the possibilities to study joint function?
Arthrography, surgery, and arthroscopy can give an impression of the function of a joint, but it is far from easy to understand the complex function of this joint by observing it through a surgical opening or through a thin arthroscope. Videotape recording of arthrography is probably the most effective way of studying joint function today. This technique is, however, not optimal for educational purposes, since the interpretation of the arthrograms requires some training. Dr. Isberg and myself studied the course of clicking temporomandibular joints in autopsy specimens by the aid of high-speed cinematography. This gave Dr. Eriksson and myself the idea of making a videotape of functional alterations of a temporomandibular joint. This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment. In this joint, the disc is also located in a superior position. The disc is biconcave, with its posterior thick part located on top of the condyle in the closed mouth position, and posterior to the condyle at maximal opening. There is, however, a small perforation in the central part of the disc. During opening movement, there is rotation in the lower compartment and more of translation in the upper compartment. There were no crepitation or clicking from this joint during movement. The location of a perforation to the central thin part of the disc is relatively unusual. In joints with disc displacement, it is our experience that perforations usually are located in the posterior attachment and not in the disc proper. When the condyle is distracted downwards from the temporal component, the perforation can be clearly seen. In this joint, the disc is anteriorly displaced. and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening, followed by clicking during closing. The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery. Reciprocal clicking is a clinical sign of anterior disc displacement with reduction. In this joint, the disc is biplanar. It's located on top of a condyle, but during opening it's slightly displaced medially, and in association with this displacement, clicking was registered. The posterior attachment between the disc and capsule is considerably thinner than in a normal case. During closing, the disc is again replaced to a more correct position between the condyle and temporal component. The disc is lying in between the condyle and temporal component, but there is a type of reciprocal clicking caused by a medial-lateral movement of a disc. The next joint has a medial displacement of a disc. During opening, the disc is moving in lateral direction, and here the disc can be seen. Now it's displaced medially anteriorly again. And here it's replaced to a more normal position and displaced again. Clinically, it can be difficult to differentiate the pure anterior displacement from an anterior or anterior medial displacement. The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle. During all mandibular movements, the disc is lying anterior to the condyle, and at maximum opening, the disc is folding downwards as seen here. There is a considerable stretching in the posterior disc attachment at maximum opening, and even if the disc is displaced, there can be a good range of motion due to deformation of the disc and stretching of a posterior disc attachment. The next joint demonstrates a large perforation of the disc. There is only a small piece of the disc remaining anterior to the condyle. This joint demonstrated crepitation and irregular movement.
I think ultimately cooperation between dentistry and Otorhinolaryngology means that our patients are going to have a better chance of enjoying better health throughout their lives. You know, I work towards doing that. You work towards doing that. Isn't that why we became doctors? To help other people and see them thrive? And let's admit it, we like it when they come back and say we're their heroes. You're always warmly welcome to contact the Institute to discuss a patient or ask questions about TMD. The door is open for you to establish this relationship, so please do so. It is one way also of doing roundtables in some sense. I mean, I know when I was first exposed at Emory, we had roundtables. There was a physician, dentist, physical therapist, nutritionist, sometimes at the same table briefly talking about a case. And I think that is a wonderful thing. And it allows for comprehensive care. And it's probably why the Mayo Clinic did so well. The three Mayo brothers, and one of them stated that good dental health will extend life 10 years. And that was proven to be true by a dentist in Michigan, Carl Misch, who went back and looked at autopsy results, ages of death, and whether they wore dentures or not. But one Mayo brother could find something the other Mayo brother didn't. They all put their heads together, and they were intellectual. And I'm not to say you're not intellectual, but what I'm saying is round tables are a good thing. It's always good to get someone else's brain involved in something that isn't clear. So who am I? I am the founder of the Atlanta Tmd Institute, which I hope will live on even after I do. I'm 66 years old, and I feel like I'm just starting, and because I'm learning more and more. That's just my interests. And so I wanted to be sure that TMD was, the information related was developed and promulgated, because honestly, it's an area much neglected in dentistry. There's no specialty. At least we are recently developing a specialty, and we're over the first hoops of developing a specialty in orofacial pain, not TMD. Can you believe that? So you're talking to me right now, and as of now, there are no curriculums in most dental schools in TMD because there's no specialty. That why are you going to teach them something that's not going to be on their dental boards? So I limit my practice of dentistry to temporomandibular disorders, orofacial pain, and sleep dentistry, and I do some oral surgery also, but I don't believe in surgery of the TM joint. The American Academy of Orofacial Pain 7 or 8 years ago had two surgeons review the literature on TMJ surgery, and their final conclusion was surgery inside that joint is very difficult. It's all heavy duty tissues, very limited, very small. It's not like the knee, and most of the time we create problems with the surgical procedures, so we want to support it orthopedically, and fortunately, because it's fibrocartilage and not cartilage like in the knee, we tend to heal. Patients tend to heal. So this is a critical thing. So I founded the Tmd Institute. We educate. We've given courses the past 2 years in Georgia primarily, but we're branching out into Alabama, South Carolina, and Tennessee, and starting to try hard to give information to dentists. And you can review my CBE at our website, www.atlantatmdinstitute.com. We educate, give courses. We'd love to start doing medical because I think that's critical. And that's why I'm basically doing this video for you. We also see patients. So I have a reasonable practice with taking referrals from all around the state of Georgia, Alabama, Tennessee, Florida, North Carolina. So the whole regional groups of dentists will very often refer to me, and I will see patients, and it's extremely interesting and very, very satisfying. But go to the AtlantaTMDInstitute.com. It's a new website. We are, my CV's there, courses that we offer. And if you're interested in referring patients, you can also go there or call directly